Theresa Duncan is a speaker and a writer with over 20 years experience in healthcare. Her areas of expertise include accounts receivable, insurance methods, helping doctors and practices really establish solid management systems. And I think you're going to see a lot of that reflected in the information that she shares. Teresa is a recipient of Educator of the Year Award by the Association of Dental Implant Auxiliaries, which is a component of ICI. And she really does understand the importance of CE, and we're so happy that she's chosen to share some time with us. She's a noted author as well, particularly one that I love called Moving Your Patient CS, Easy Insurance Conversations. Excuse me, Teresa. And she's an annual contributing editor to the ADA CDT Companion Guide since 2017. Lastly, Teresa is a frequent contributor to The Observer, The Progressive Dentist, and Dr. Bicuspid, and she served as a founding trustee for the Auxiliary Learning Focused Dale Foundation. It's really our pleasure to have tonight's speaker with us, Teresa Duncan. Teresa, please take it away.
Thank you so much, David. So welcome, everyone. I know that an evening, I know some of you are at 7 o'clock. I'm on the East Coast, so 7 o'clock taking an insurance class. I'm pretty impressed by that. We're going to talk about some laser billing and coding strategies. Now, what I mean by strategies are we're going to make sure that we stay ethical, that we stay completely, I guess, using everything that we have at our disposal in order to get our claims paid. There's a couple ways of going around that or accomplishing that. And I want to walk through some of the basics that we need to have in place. Then we're going to go over some procedures that as laser users, you're using the most of. And then we're going to wrap it up with a little bit of a talk on a HIPAA form that I get a ton of questions about. So we're going to wrap it up with that. So let's go ahead and move forward. I've been saying this phrase for a long time. Your documentation will drive your revenue. Now more than ever, this is really becoming the case. So, and I apologize if you've heard me speak before, because you probably have this drilled into your brain at this point. But why I say that the revenue is going to be affected by your documentation is because it's very easy for a claim to get denied or to get just lost in the shuffle if the correct documentation is not applied. I don't think a lot of people understand just how much it costs to reprocess the same claim over and over again, or for somebody like your insurance coordinator or your manager to send the same information over and over again. And so if we can have good documentation that is really solid and just very easy to read, that's what we want to send with them initially. And for so many years that I've trained on insurance best practices, I can tell you that one of the biggest issues, if not the biggest issue, is that the documentation that we're armed with in order to get the claims paid just is not as good as we would like it to be. Now, I'm not saying that it's terrible. Sometimes it is, but not for everyone. It's just that the standards now for how complete a record is, they're just it's coming at us hard and fast. So let's talk about this. Your clinical notes should be as complete as possible. And doctors, I'm sure you're kind of feeling like this person in the picture, because when I say that, I can tell doctors in the audience are going, my notes are great. And then, they realize they have to take a look at it every year. I want you to take a look at it every year because you have new technologies, new procedures, new materials that you're using. So make sure that any templates or any clinical notes that you have set to go reflect all of this newness. It's current, right? Now, the industry as a whole, insurance industry, is moving away from narratives to screenshots. So if you're a brand new dentist or insurance coordinator and you're wondering, what's that about? Typically, we would send in with any documentation such as an X-ray or intraoral image, we would send in a narrative to explain why this tooth needed the work done, right? Well, now the industry is moving away from our narratives to screenshots of the clinical notes. So us insurance coordinators, we're pretty happy about this because it's less work on our side, but it's less work for us only if the clinical notes are up to par. And so this is actually a team effort that I'd like you to really grab the bull by the horns if you don't think this is in step in your office, only because, remember what I said, if it's not up to par, your person is going to be spending a lot of time delaying getting your claims paid. It's a big back and forth when you can't get your claims paid on the first time. So When I say that they're moving to screenshots, this started back in about 2018. I saw one of the deltas, Northeast Delta, had put that out in their manual, and I thought, this is different. Well, this year, National Delta Dental has included it in their manual. So it's really becoming an industry standard. I know a lot of doctors who do the insurance consultations. Work with carriers as well as providers and companies. And they have told me that it's much easier to read clinical notes, shocker, than somebody's narrative. So start looking at changing up your documentation in that way. Intraoral images are like gold. I will say this in classes, and all of my coordinators will, yes, nod their head, because I can get a lot paid with an x-ray plus a good clear intraoral image versus just an x-ray. So if you're not a fan of taking a lot of intraoral images, might be time to step that up. And if you are already taking great intraoral images, I want to pat you on the back, because that's actually, that I can't tell you how helpful that is. All right, if somebody comes in and you don't have their previous record, they say they're going to have it sent to you, all this kind of stuff. Make sure that you note that in the record, so that if there's any requests for information from the past, you have that. We don't have to wonder what happened. Did she come in? I mean, it's usually like, 3 or 4 or 5 years later. So if and this is on your administrative team, if somebody comes in with no records and they don't follow through, make sure that's in the documentation as well. It's very helpful for that. And then you'll find out how helpful that is when you have to deal with it. It's one of those things you really don't need to deal with on a regular basis, but when you do, you're very thankful. So let's talk about how we're supposed to get that documentation, and then we're going to get into the coding part of it. So at the comprehensive or the periodontal evaluation, that's the ideal time to record all of the diagnostic information. I'm not going to go into things like SOAP notes and all of that, but and I know, clinicians, that we need to have some sort of assessment made, and then there has to be some sort of diagnosis made. There's a lot going on. You may be having a diagnosis for perio, diagnosis for caries, low risk, high risk, all of that. That is the great time to put that together is at the first time that you do an evaluation. So think about it from your insurance coordinator point of view. If I were your insurance coordinator, when I'm looking for diagnosis for specific procedures and it for some reason does not make it into your notes for the day, I can go back to your comprehensive evaluation and see all of that. I want you to make sure that you note any missing teeth. That really helps out, because sometimes teeth numbers get a little bit misnumbered, but when you have that all documented correctly the first time, that really helps. And templates, of course, are going to be the real big help here. I will admit that I know if you're not working with a full staff, I know staffing has been an issue for offices across the country. If you're not working with a full staff, it's hard to find the time to do complete charting like you would prefer to. But the ideal time is to have an assistant, either the hygienist or a dental assistant, maybe even your admin, if they have time to sit there and chart with you. I do think it's super important. And also, I'm not going to talk about it here, but from a legal point of view, you need that. So your lawyer would thank you for that. Okay, so when it comes to radiographs, one key thing that you need to remember is that all of the carriers, when they're getting ready to approve benefits, what they're looking for is that they have to approve benefits based on documentation that's within their guidelines. So say Dr. Ford is a dental consultant looking at your claims. Dr. Ford sees this great radiograph, it's perfect. And he's like, oh, great, I'm going to go ahead and approve benefits. And then he goes, ooh, this is a 3-year-old radiograph. According to the contract, he can't approve benefits because most carriers want x-rays to be within 24 months. So that's a really good argument to have very, very recent x-rays. And they have to be clear. They can't be cone cut, open bite, all that stuff, right? So we have to make sure they're good quality, labeled. I did say 24 months for the radiographs, but I have been hearing that there are some plans out there that are 12 months, but that's not a huge clamor that I'm hearing. I typically get notified when people run into crazy cases like that. And I don't see that often, but I would keep an eye out for it. Full probing accepted across the industry is within the last year. So since we're talking a lot about laser procedures today, and a lot of them perio, that's super important. So we need to make sure we have very current probing, complete, lots of colors in it. I want to see pus, suppuration, furcation, bleeding, just as many colors as you can on there, because that's really what they're looking for. They're looking for clinical attachment level, not probing depth. So make sure that your setting is set to clinical attachment level. All right, recording the missing teeth, we talked about that. What we're looking for too with intraoral images is we're asking you for them more and more. You probably have noticed, because there are requirements for crown buildups and crowns. Also, some perio have been asking for intraoral images too, but by far, crown buildups and crowns or bridges with any buildups, they're requesting intraoral images before and after. And the reason being, it may not be because they just want to make your life miserable. It really has to do with the amount of fraud that's in the industry, and having been to many claim reviews sessions with dental consultants over the years, I can tell you that the fraud problem in dentistry is really upsetting and worse than we could ever imagine, to be honest. So that's why, not making an excuse for it, because it stinks. I've run into it too, but there's a reason why you may get requests for intraoral images where you never did before. So another reason why I think it's really important for us to know what we're doing. Have a great complete picture of the oral condition with radiographs, with the intraoral images, with the charting, with the probing. So I can take a look at it, just like the consultant can take a look at it, and know exactly what the health of that tooth is. All right, so the patient's periodontal path, and I'm going to just focus on perio for a little bit, because that is the majority of the questions that I get when it comes to also laser. So, and also perio in general, perio, crown buildups, and how to process secondary insurance and all of that. Those are typically the hot button items. So with the patient, what I'd like for your team to do is get together and think about what the patient's periodontal path is. How do they go through your office? And this is super important when you have a bunch of clinicians that are working together. As you know, some clinicians are more aggressive than others, some are more conservative than others, right? So there needs to be some consensus in the office so that the admin team member is aware of the protocols, or if one's a complete outlier, we know at least to be heads up with this particular provider. But there needs to be some sort of consistency also for the patient experience. Sometimes patients don't mind seeing different providers all the time. And it's really not a good look when one hygienist is telling them nothing's wrong and the next hygienist is diagnosing, deep pockets and all sorts of stuff. So get together with the team and talk about the way the patient goes through your practice. Do they have the new patient exam? Who does the probing at that time? What's the criteria for debridement? When do we get them into the soft tissue program? What do we do if there's just inflammation but no bone loss? There's that code 4346. Then are you doing any antimicrobials, any home care? What is the recommended intervals? Who makes that call? The doctor should make the call. I understand that, but a lot of times the hygienists have serious input into that. So that all needs to be discussed. So this is not really a slide I'm going to spend that much time on. It's more of a homework assignment for you. And like David said, you're going to get a handout that has all of this information on it. And what I'd like you to do is go back, and if you're the only one from your office listening to this, please go back and share this information. I know the recording will be available also. If it's something that is just, you're just like, I can't repeat all this, send them the link when you get it and have the clinical team pay attention to this too. That way everybody's on board, right? Okay, so for those of you who are using the laser, you're probably using the Repair Perio protocol. I am not a clinician, not even a hygienist. I was an assistant for a while and I was terrible at it, I'll admit it. So I moved up to the admin side. That's where I really shine. So I'm not going to go through all this and pretend that I know everything here. You have this in handouts. You've been taught this also with the clinicians that are helping you. But when I look at this, I see a big opportunity for you to teach your team what is involved in all of these steps. So what I did is I took the protocol from, Dr. Lau and the other clinicians, and I said, let me go ahead and code this for you so you have it. So you have here some example codes that you could use. These are the codes that I would use when I'm going through and having this procedure, say, in my office. I wanted to point out one evaluation code down at the bottom, reevaluation of a visit. D0171 is a relatively newer code, but it's really underutilized. When you have somebody come back for an evaluation visit and it's after, say, the osseous surgery or after you did any surgery, really, if you have them come back in for observation, it's not it's not a free evaluation. I know a lot of doctors will say, well, it's just a look-see. It didn't take me very long, but you had overhead that was associated with that, and you have a code that you could bill out for that. Will it use up one of the frequency limitations for the patient's evaluations? Sure, but it's the patient's healthcare, right? So if the code is there and you feel comfortable using it, I would, because that is some time. And also you're making a clinical call. You're deciding whether or not there's healing involved. I would absolutely use that code. So criminally underused, I can tell you when I take a look at a lot of files or taking a look at having an audit, a records audit, I will see a lot of none of this reevaluation, and there's a lot of other evaluation codes. And I really don't see a lot of 4910s to, believe it or not. So, and I actually am not going to talk about 4910s, but that is also, I think, a protocol that I would get together with the team and decide how you're going to message that to your patients too. All right, here's the documentation. And if you're a BIOLASE owner, then you have a copy of the coding guide that I wrote for them, and it will be updated because we have some changes on it, but it is available to laser owners. And in that, we took the documentation for the laser and put it together, just made a list for you here. And that way you can check it against the templates that you have and see if you're missing anything. So, I mean, I'm obviously not going to go through each of it because it's, some of you are going to go to sleep with it, but there's a lot here. Were there any radiographs? Where's the diagnosis for the radiographs? What's the diagnosis for the procedure that you're doing? The area of treatment, believe it or not, I know that you're saying, next visit, last record entry, it says next visit left side, but you don't mention it in this visit, then we need to make sure that that's there. So anesthetic agent, I mean, it's simple things like that. But if you are delegating the notes part to someone, and this is how really efficient practices work, is the clinician knows that the notes are going to be completed very well by the assistant, and then the clinician reviews it and signs off on it. This is why I want to make it foolproof, have everything in there that's possible. If it doesn't apply, get rid of it. But I don't want to take a chance of having you be on the stand and there's a really key piece of information that's missing. That's actually my biggest fear for doctors that I work with. I just don't want that to happen. So, and also the laser settings, you see that down there. Those are the setting criteria that I want to make sure that you have in your notes. And again, have it just blank like that, and then make sure that it's filled out along the way when your assistant is filling that out. Okay, that's a lot, right? And that's what I mean. This is kind of homework for you. You're going to have to go through that and make sure it matches your templates. One piece of information that I think a lot of offices aren't using yet, and I'm seeing it a lot more in the last 6 months, I definitely have, when I'm talking to offices, is the new periodontal classifications that came out really about 2018, 2019 is when they started really spreading out there. The World Health Organization and the Periodontal Association, perio.org is where you can go to get this information. And in the handout, the PDF, there, if you click on the this slide, I have it linked so you can go directly to there so you can get your own copies. But basically, we now have new classification criteria. So this year, I don't see anything in the manuals that state that you have to have the patient staged or graded, and I'll get into that in a second. But I suspect for 2022 and 2023, definitely by 2023, maybe 2022, this will become part of the documentation. When you send in a claim for scaling and root planing, I'm pretty sure you're going to have the staging of the patient, and then for 4910s down the road, the grading of the patient. Now, what am I talking about? So staging is when the patient comes in, you're assessing what stage they're at with perio disease. So healthy people, you're not doing this, right? But for people who have signs, symptoms of periodontal disease, you're going to stage them. Now, and again, not clinical, so I'm not going to go through all of this. I'm just trying to explain it in layman's terms to you. The grading piece is after the procedures are done, the treatment is rendered, and the grading actually measures the healing. So if the patient's grading well, that means that they're healing well. If they're not grading well, that means that it's slow healing. Maybe there's still a lot of risk factors involved, non-compliance, all sorts of things there. When it comes to 4910, you can see, and that's your periodontal maintenance, you can see how important it is to have the patient's grade in order to have reimbursement come a lot easier. Now, if you noticed, I should have pointed this out earlier. If you notice when I've talked, I have not said that you should do this or you should do that, or the procedure should be done here or should not be done. That's not what I'm saying. When I'm talking about benefits, what I mean is if we're able to get the benefits or if we're able to obtain benefits. Under no circumstance do I want you to make decisions based on patient's coverage. I know that we try to be nice and we try to get as much coverage for the patient. I get it. But at the end of the day, the patient has to be responsible for their health. Our job, my job specifically as your insurance coordinator, is to try to get as much of those benefits available to us. But sometimes benefits aren't there. And so it's on us to make sure that the patient is aware of that. But under no circumstance does it mean that if there's no benefits available, that you shouldn't do the procedure. You do what you need to do. Let me and the insurance coordinators figure out the benefits part and have those conversations with your team. So you have here 3 handouts that you can print full page and go over. There's also guides you can go over with your team. So everybody's straight. Throw this into the Perio pathway assignment that I gave you. And you can see there's steps to it. And everybody's going to have to be on board. It's really not helpful when one doctor's doing this, but 3 others aren't. We need to get everybody going. So you can set a date that's down the road because, like I said, it's not become mandatory yet, but mandatory for benefits, but I'm pretty sure it's coming. And also, since these are the new classifications that the AAP is putting forth, this is standard of care. So will you be held to this standard if it does become a legal issue? Probably, most likely. So I would get going on this and have them in your office. It's a good project for anybody who's clinically minded and wants to get this going. Okay, so let's talk about the scaling and root planing. What I definitely recommend, and David mentioned my book, which is about insurance conversations. We talk about the fact that the patient has to be aware of what the potential cost is. I like to say to them always that it may be covered at this amount. We expect that we'll be able to get this, but I always make a laugh or joke and say, this is what I think is going to happen. Your insurance company may be doing something different, but I'm telling you, from what I think right now, this is what we're going to get. Based on my experience, this is how much you're going to have out of pocket. And the way that I phrase it is that I'm letting you know things happen, but I'm going to let you know along the way. Like if anything goes wrong too, I'll say to them, if I see something that's really different with your plans that I did not anticipate, I'm going to contact you as soon as possible. I also make this statement. It's not on the handout actually, so I apologize. I make this statement. I will try to get as much of your benefits as possible, but if I need you to help me, then you can tell that I'm at the end of my rope with it and I really need your help. So I'm already prepping the patient that if I need them to step in, call the carrier or go to HR, it's because I've done everything that I can. So I say that ahead of time during the treatment presentation so that they're aware that, something's up if I have to try to get in touch with them. Typically, benefits for scaling and root planing are subjected to 24 or 36-month frequency limitations. Seems fair to me, right? And actually, all this information that I'm going to give you about the different clauses that are attached typically can be found in the patient's benefits booklet. When you call to get benefits verification, a lot of times these little clauses are put in these printouts that you'll get. So your insurance coordinator is going to learn a lot if they're consistently reading this information. We talked about the periodontal classifications. Oh, I skipped this. I'm so sorry. Must show evidence of the clinical attachment loss. And I have seen a real big change from having pocket or clinical attachment level being 4 to 5 millimeters to now we're starting to see 4 to 6 millimeters. And it's just creeping up. It's creeping up. I'm a little concerned with that. I'm not even clinical, but at some point, there needs to be a talk with the patient that although the benefits may not be available because this is their criteria, my criteria as a clinician is that I think that you have active periodontal disease and I would like to treat it. So again, make sure that you set that recommendation that this is what I think, but this is what your benefits may come in as. And that's real life, right? Okay, radiographs, intraoral images, we talked about that. I would love for you to note the seat and dismissal time. One thing that we have seen with scaling and route planning over the last 2 years is that if they come back at you with additional information requests, what we're seeing is they are asking for a copy of your schedule, or they're asking for the duration of the appointment. Again, this is because there is so much fraud in this area, but I want you to have an answer. So actually, for all of your templates, I don't think it's a bad idea to enter in the seat and dismissal time. It's helpful for you. If any of you are doing anesthesia or any medically involved procedures, you're probably already doing this. In medical, there's definitely procedures that are billed by time element. I just would love for you to be able to have that so you don't have to go and send a copy of the schedule, which is what you ultimately will have to do if you don't have that information. And that's always, that really does seem like a bit much, but it definitely has happened. Actually, a lot. Okay, so common clauses that really surprise us, so I want you to pay attention to this, is 2 quadrants payable per date. What's really interesting is that 4 quadrants in one date, there's a lot of clinical research that shows it's ideal to do all 4 quads on one day because you don't have the bad bugs reinfecting the clean sides and all of that. But for the longest time, it's been 2 quadrants payable per date. I really don't know what the criteria is for that other than limiting benefits. However, I have been told by one, I work with a lot of the outsourcing companies, I keep in touch with them. One outsourcing company was telling me that they've seen guidelines that patients who need it, they determine need it, should have all 4 quads done at one time. I find that a little bit invasive as far as looking at procedure recommendations. It feels a little bit like a diagnosis coming from outside of the office, but I don't know enough about that. So I would just keep an eye out for that. Typically it's 7 days between the visits, and I don't like that either. I would love for them to come back in as soon as possible. Irrigation while you're doing it, and you can bill for it because there is a code 4921. It's typically not going to be covered. So you need to make sure the patient is aware of that. If you're in a participating network and they ask you that, they tell you that it needs to be written off because that's the price you've agreed, that's also a loss as well. So one thing that surprises, one clause that surprises a lot of people is that if you do the scaling and route planning and then you do the evaluation appointment, which again, D0171, within 90 days of that, if you do a 4910, see the patient for the perio maintenance, within 90 days, it's actually considered to be part of the overall procedure. This is if you're a participating provider. That means as a PPO provider, you're going to have to write that off and take that loss. So is it worth it to go 91 days out? Sure. If it's not going to compromise the patient's care, let's make it easier. But that's not really affecting your treatment, whether or not you're going to do it. It's just helping the patient be able to access their benefits. Okay, and for perio maintenance, typically up to 4 times a year, we see it covered. If the patient has any additional health issues, being pregnant, it's not really an issue, but if they're pregnant, for example, or if they have diabetes, if their plan offers additional cleanings because of that, they will need to make sure that they let their dental carrier know. A lot of times, 3rd and 4th perio maintenances in those situations are covered, which is great. But we definitely are seeing most of the time 3 to 4 times a year, but there are still an awful lot of plans that are still 2 times per year. You're just going to have to know the patient's benefits and make sure that you let the patient know what's going to be not covered so they can plan financially for it. And you can see here the difference between x-rays and intraoral images. This is the same set of teeth, and you can see if I have the 2 together, I can definitely get things paid. So there's my argument for intraoral images. You've probably seen it too, doctors and hygienists. You've probably seen the exact same case and you just didn't think about it. But if you ever see something like that in the operatory and you have a new insurance coordinator or somebody that's still learning the ropes, show them this so that they know what they're looking at. Okay, gingivectomies. There's necessary documentation. So the next couple slides is me going through a ton of benefit booklets, manuals for the different carriers, and getting the most giving you the most frequent clauses that I have found. So this is not comprehensive. This isn't every carrier, but these are the clauses that I found, which means these are the clauses I want you to look out for. So for benefits to be applied for gingivectomies, they are looking for 5 to 8 millimeters of attachment loss. That's common. I saw that very often in the benefit booklets. Still need to send in all of the radiographs, probing. If you have progressive probing, meaning you have the comparative probing, say you have a set from 2015, now you have probing the complete chart for 2020. If there's a big change, do one of those comparisons that your software can do. And if you've never done that before, it's fantastic. It helps me a lot when I'm talking to patients about the care too. Print out a comparison chart and you can send that along with it too. Same thing for your scaling and root planings. If they have to have it redone, you can show the progression of their bone so that you can, it's very obvious why they need to have the work done. The thing with gingivectomies, I don't really think this makes a lot of sense, but again, not a dentist. Most of the plans will only reimburse if you have it done on a different date than the crown prep. And that's a very, very common actually plan. So again, you're going to need to let the patient know that it'll be benefited if we do it on a separate day. Now, I understand you may not want to do it on a separate day, but the patient does have a right to know that it would be benefited on a separate day. We as dental providers, again, I'm not a clinician, it's up to us to give them that choice so that they can make the choice for themselves. Okay, anatomical crown exposure, all these big words. They're really not going to reimburse that on the same day. They really see this as cosmetic. I didn't see very many cases where this would be covered. And so I always, again, let the patient know, in my experience, there's not a lot of coverage for this particular procedure. I'm going to try. I'm going to send in everything that I can. I'll let you know if I'm unsuccessful, but most likely I'm probably not going to get any benefits for it. So I always prepare them for this. Okay, crown lengthening. What I have seen, I'm just going to jump down to the third bullet point because you already know about radiographs. This I have seen in a lot of manuals. So for clinical crown lengthening, this must include alveolar bone recontouring. That popped up a lot. So if it pops up a lot, I'm going to tell you about it. So is this something that if you actually do it, you should have in your notes, maybe part of your template? Absolutely. And that's what I'm talking about. Maybe you saw it and it just, maybe you didn't write it, maybe it just didn't occur to you to put it in there because it was intuitive. If you have a template, it's there and you can say, oh yeah, and you can click it. And if it's not there, you just delete it. You delete it out of your template. So that's why I'm a fan of templates. So they are looking for the evidence of the decay, any fracture that extends below or near the alveolar crest. These are all the big clinical words here. That's really what they're looking for. So I'm going to make sure that my templates have that information, those terms in there. And that way, when I take a screenshot of it and send it in to the reviewing dentist, these are the terms they're going to be looking for because those are the terms that are in the contracts they have to abide by. So if it's applicable, I'm going to make it as easy as possible on them to approve the procedure. I am all about making your claims as easy as possible for me to get things paid. Now, I wanted to point out in the definition of 4249, the crown lengthening, there's a requirement there. Reflection of a full thickness flap and removal of bone is actually part of the requirement. So again, is that something that I would have as part of the clinical notes? Yes. And then also performed in a healthy periodontal environment. So if you send in x-rays and there's, perio all over the place, that's going to be a reason for denial. So you can see that that's a problem. Okay. Osseous surgery. Now I have this little purple box or purple circle that pops up and it's medical billing. So when you see that, that means that these are procedures that could be billed to medical. And I'm going to tell you right now, I'm not good at it. So I'm going to include at the end, I have a list of people I'm going to send you to. I am not good at medical billing, so I can't help you with it. I just know to direct you to people who are really good. Okay, so for osseous surgery, the code itself states that bone has to be augmented or removed. And so that means your notes must state that. If there's nothing in there, that's automatic. I mean, every time I've had to appeal this and there's no information in there on that, I know it's going to be a really hard road. We probably aren't going to get it covered. So my periodontal charting and radiographs are still going to apply. I mean, you can tell it's pretty universal, right? So you're going to have to make sure that you have those updated. If there's a history of scaling and root planing, previous surgery, I want to make sure that's part of the record as well, so that I can notify the reviewing dentist that that there is a history here. And again, if I have my periodontal classifications, it's a much easier case to make as well. So it's these requirements here. It feels like I'm teaching to make sure that the consultant reviewer is happy. But in reality, as a participating provider, that is what we have to do. We have to make sure that our documentation is super easy to read, comprehend, and quick to be quick for them to move on. They have a lot of claims that they have to get through, the consultant reviewers. I don't want yours to stand out. Do you know what I mean? I don't want them to stop on yours. I want them to see it. Oh, okay, that makes sense. Yeah, x-rays match, code. Yeah, this is all good. On to the next person. Because the claims that they get stopped and they have to read, they have to decipher, you know, I wouldn't be in a good mood either. So I kind of feel like if I were a teacher and I had a student that gave me an essay that just didn't make a lot of sense, you know, that must be how they feel like. And that's why I want to make sure that you don't stand out. Standing out to an insurance consultant reviewer is really not a good thing. All right, so I gave you the codes down there that would be applicable. Okay, I get this question a lot from laser users, hygienists that take my class. I love when hygienists take my class. It tells me that they're ready to take it to the next level as far as making sure procedures get reimbursed for, and they're curious. I really like that. So it's important to remember that there really is no code for LBR. It's just not there. Right now, the only code that we have available to us is the 4999. Any code that ends in a 999 is what we call a miscellaneous code, meaning you have to send in a report. It's your screenshot of your clinical notes, but typically it's not covered. Now, will you get an EOB back that says you can bill the patient? I hope so. And of course, if you're out of network, then you can bill the patient for this, whatever you feel like the fee should be, whatever you can justify it as. Most most networks will go ahead and bundle it with the other procedures or outright deny it. So typically not going to be covered, which I know is a bummer. I know it's a bummer because it's obviously a separate procedure. However, it just hasn't caught up here. And I'll show you the 2021 Delta Dental Manual. And if you're a true insurance geek, you probably have a copy of it. There's not a lot of us out there, but I get it. So I pulled up my copy of the Delta Dental Manual and I saw that everywhere in the categories is this phrase: laser disinfection as a standalone procedure is denied as investigational. So it's not coming from me. It's coming from the big Delta Dental, and the other carriers also have similar language. So what I would do again is just make sure that your patients are aware of the extra cost and collect from them at the time of service. Now, I mentioned that there's a HIPAA form that you can use to have the patient pay up front. I'm going to have that at the end because that is probably the most frequently asked question when I'm talking to people about higher end procedures, like cosmetic upgrades and things like that. So let's make sure that we talk about that. All right, my purple circle pops up again for frenectomy and frenuloplasty. I always have to read that so I don't mess up. This year, 2021, we retiring the 7960, which was just a catch-all frenectomy code, and we now have two different frenectomy codes: buccal, labial, and then the lingual. So they needed to make sure that they could parse that out, because what was happening is we would send in a code for the frenectomy and there would always be a letter that came back that said, well, where is it? So they just made it easier and gave us separate codes for it. So make sure that your software is up to date with all of that. And if you're curious about the new codes that are out there, go over to my website. You'll have that information in the handout. Go over to my website and check out the media section where the webinars are. And every year I do a coding update. So we did 2021. I do a coding update every year in January, and the link to watch the replay of it is there in my list of webinars, along with a couple other free webinars too, if you're inclined. So coverage typically available. If it interferes with proper oral care, does have to be in your notes, obviously. And if there's a prosthetic that's, you can't seat it properly, that's going to be a good reason. And then if there's causing issues with speech or mastication, the chewing, and future, if you can, and that's why we do it on children, is because we can see it's going to be an issue. Now, these 3 bullet points are what I found to be in almost all across the board. If there were benefits for this, they were for these reasons. They would prove benefits for these reasons. Now, I will tell you that most of the pediatric doctors that I know are billing this to medical, especially if they're working at a surgical center or a hospital. So actually, you guys are probably on top of it if you're doing that. But for the most part, this is a very medically billable procedure. So if you're looking to expand on that, take a good class. The first person that I listed in the handout for the resources actually has a series of webinars coming up. She has an academy, and it's very helpful. I find her information to be very, very helpful. So make sure that you have everything documented. And especially if you build a medical, what you'll find is it has to be very, very detailed. All right, don't forget that reevaluation code. Put that down there to remind you. Same thing for biopsy and excisions. Medical billing is perfect for this. It's not going to be reimbursed on the same day as a restorative procedure. So, and that makes sense. But again, if you want to do it on the same day, you're going to need to let the patient know that there might be an out-of-pocket cost for that, because that's not going to be approved. So lots of things that you can use your handy laser for. Typically denied. I didn't see very much coverage for these codes at all, and so I'm really not going to talk about it. Just really not much coverage. Almost all of them. In fact, if they're on this list, actually, I did not find benefits for any plan for these procedures. So, and I know that they're good for lasers too. I mean, lasers are perfect for these procedures, but that doesn't always mean that there's going to be benefit for it. Removal of the tori, to be honest, I would actually attempt medical billing with that as well. I know one office, a pediatric practice, that is able to do that. They have a whole billing department. A medical billing department is pretty amazing. All right, so the big question that I get is, well, if something's not covered, let's talk about LBR. Let's talk about the bacterial reduction. Let's take that as an example. What if I just get them to sign a form? Can't I do that? So if you're at a network, you can just sit back and ignore this part of the conversation because this doesn't apply to you. If you are in network, however, this is something that at some point you probably read on a forum or talked to somebody at a dental society meeting and they were like, oh, I get around this all the time and I do this. The form is there and the form is handy to use, but there are some caveats that go along with the form. And I just want you to know this before you go in and take a leap. This is HIPAA. So this is going to be part of the HIPAA regulations, and HIPAA fines are not small peanuts. So just make sure that you're doing it correctly. You may even want to ask your HIPAA trainer about this. So basically what you're doing is you're having the patient sign a right to restrict disclosure form. Basically, the patient saying, please don't send in claims for this procedure to my carrier because I don't want them to know about it. I'm going to pay you for it out of pocket. So this is how a lot of people get, maybe say the veneers, they had the patient pay for the veneers if the plan is telling them to write off a significant amount. And same thing with LBR. A lot of people will charge a good amount for LBR, even if they were a participating provider. That plan may actually ask them to write that off. They may be obligated to write it off, but using this form circumvents that. Okay, so what you need to do, and I'm sending you to Rick Garofalo. He's the owner of Practice Mechanic, and I'm going to send you to his site. And this is a free resource. He gives it to everybody. He's always offering it up in his Facebook group. Go to the resources section and download the Do Not Bill Insurance form. There's a lot of forms there. Go to Do Not Bill Insurance and download it and read the directions that come with it. The big takeaways I want you to know, because I don't want you to get in trouble, is that it applies to the services for that day and that day only. And the patient has to pay in full at the time of this day's services. So that's the big kicker. So a lot of people think, oh, we can have them make payment on it. But according to the regulations, the payment's got to be made in full for that day. Now, the big thing that I've been personally involved with is it can be revoked at any time. So I'll just give you an anecdote. Actually, not even an anecdote. It really did happen, right? I was on the phone with a friend of mine who is an insurance coordinator. She said, can you help me with this? I said, sure. The patient had signed a form for cosmetic upgrade and used this form for it. And the insurance company told them, well, you shouldn't have signed that form. If you didn't sign that form, then they would have had to write it off. And the patient was like, basically she's like, wait a minute, I signed the form just to pay money. That doesn't make any sense. And it was in the way that it had been explained to the patient. So we were on the phone with the insurance company. I was conferenced in, and the rep was basically telling, this is all happening. The rep was telling the patient, you need to be repaid. And a letter was sent formally, and that office did have to repay that patient because technically it didn't apply. The patient actually revoked. And so the patient can revoke at any time. And that's what scares me, is that the patient's going to find out that they probably didn't need to pay you that amount. And then they're going to revoke, and then it's just a big headache. So that's my caveat. But if you have a system going and it's working well for you, I'm not one to break a system. I just want you to be aware of the implications or the consequences of what could happen if the patient does revoke. It becomes very, very messy. All right. So I hope that you remember the terms. I know we're going to get into some questions here. Remember this quote: your documentation is going to drive your revenue. And if you take a lot more classes from me, you're going to hear it over and over again. It's going to drive your revenue. So make sure your documentation is up to par. Here are the resources I want you to have for insurance billing. There's everything that you need, lots of webinars there. Every year, get a new copy of the CDT guidebook because the codes change every year, and the changes are getting more and more substantial, to be honest. They're getting more granular. So resources for medical billing. If you go to Links to Success, that's the first one. I was telling you she has an academy with a series of webinars on medical billing. She has that. Terry Bradley is somebody who is well known in the oral maxillofacial world. So all of them are great. Every one of them that's on here are great. And I hope that you're able to get some good training from them before you do it. Do not experiment with medical billing. And you'll have a clickable link in the PDF. This is a complimentary ebook that I wrote. It's part of a bigger book of 50 plus pages. It's free. I wrote a little guidebook, Today's Insurance Coordinator, and it walks you through all of the positions, gives you checklists and all of that. So I hope that it's very helpful. Here's my podcast. You'll get clickable links for that too. I have one that's sort of fun. Chew on this. We have a good time. Nobody told me that is more, it's more management and insurance minded. So hopefully you'll be able to enjoy those. So with that being said, David's going to come back on. I think we're going to do some questions and we're going to wrap up some CE. Here's my information. Connect with me on social media. On my website, I have a newsletter that I send out. You can sign up for the newsletter. And hopefully this has been helpful, even if some of you are thinking it's close to bedtime.
Thank you so much, Teresa. As usual, very engaging and informative. I really appreciate it. We do have probably 6 or 7 questions, and I think we have plenty of time to get through those, so we'll get started. I do want to encourage everyone to really dig into the resources that Teresa has just offered you, certainly beyond herself, especially as it gets into medical. But between podcast and book and accessibility, she's such a great resource. She's a great friend of BIOLASE. We always, when we have questions, we go to Teresa because it's like going to the top of the mountain. So please don't be afraid to engage with her. She does this very well. She's really the best at what she does. And I think, scheduling time with her and getting her into your office is really a great opportunity for all of you. So having said that, let's get to some questions. First one is from Sandra. And Sandra asks, can you charge a D0171 after a debridement? You are evaluating how the patient responded and needs prophy or SRP.
You could if you weren't doing a comprehensive at the time. So typically the 4355 is in order to enable a comprehensive or periodontal evaluation. So if you're having them come in just to make sure everything is okay, you could do that. I mean, it fits, but I would imagine that the next logical evaluation would be the comprehensive at that time.
Thank you. This is from Brianna. If you do a D4346 and have them come in for a 1-month follow-up to reevaluate gums, is this when you could also use the code D0171?
I'm telling you, this is a popular code once you're aware of it. Yes, actually, that's a perfect reason. That's a perfect time to use it because you are doing a reevaluation and reassessment. So absolutely.
Oh, great. Excellent. Let's see. That's about handouts. So we've talked about that. Sorry about that. So this is from Caesar. SRP. would it cover all 4 quads in the same visit if it was 1 to 3 teeth per quad?
Typically, yeah, actually, if you do it and you have the documentation to prove that all 4 quads it was beneficial, yeah, I mean, you would be able to get it covered. Here's one thing that I've noticed, that a lot of times the carriers are very quick to downgrade a 4341 to a 4342. So that's why I say I don't think that there'd be any issues with that. A caveat I want to give you, or actually just some help I want to give you with billing everything on one day, is that there should be something in your chart that explains why that it was billed in one day. And my favorite clause that I like to pull out there, because this is true, is that you inform the patient of the risk of doing it in 2 separate visits versus 1. And because of the bacterial load, you see where I'm going here, because of the bacterial load and the risk, the patient opted to have it all done in one day. Also, if the patient has any extenuating circumstances that make it difficult, perhaps they're in a very rural area and it's very hard for them to get to you. Perhaps they're on medication that they don't want to stop, a blood thinner, something like that. If there's anything like that going on, even COVID concern, actually, I'm glad I remembered that. One patient or one office was telling me they had their all 4 quads covered because the patient had COVID concerns, didn't want to come in more than was necessary. And they were able to get that paid too. So just make sure you have good documentation as to why 4 quads was chosen and agreed to by the patient.
Thank you for that. So we got a little flurry of 3 or 4 more, but I think we're still in pretty good shape.
Okay.
So this question is from Amy. Delta Dental will say that you cannot charge the patient for laser or perioscopy. How do you get reimbursement for Delta Dental patients?
So the problem is that and let me just, I hope nobody takes offense to this. The problem that I've run into is that a lot of offices think that because there's a laser involved, that there should be a separate code or there should be a higher code for it. For the ones where there are no actually, I mean, and really what you're looking at is that you're going to be faster and it's a patient benefit. So I understand that there's going to be no payment for those services if it's done by a laser. Probably what they're doing is denying it because the laser was provided. In that case, and I know this is a little bit next level, I would appeal that and I would ask them for the alternate benefit of the other procedure that would have been, covered had you not used a laser by traditional methods. I've been able to have those procedures covered after appeal. Sometimes it takes a little bit. This actually ties in with another question that we received ahead of time, and it's similar. Wanda was asking if a silver filling, we were doing this for silver fillings, how can we get reimbursed more for fillings? Well, there's no, even troughing is included in that charge. So really there's no extra charge for it. It's really a benefit to the patient. And ideally you'd get faster with it. So it's a benefit for you. You'd save time and money. I would love for us to get to a day where laser services are benefited differently, but I just don't see that happening in the near future. So try to look at it as being more efficient with how you provide care. I hope that answered the question.
Excellent. It sounds like it did to me anyway, okay. Teresa, so we'll go with that, okay?
Thanks, David.
And that really actually touches a couple of the other ones that were similar. So I'll go to 1 or 2 maybe that aren't so similar. Hang on one second, I apologize. Does 01, this is from Jane, does 0171 need to have the doctor's hands in the patient's mouth?
Yes. So all evaluation codes have to be done by the doctor. So screening codes can be done by a delegated auxiliary that's licensed to do that, which would be an RDH. But evaluation codes are almost always to be done by the provider. So yes, and in my documentation, in my reading, that makes sense.
Okay, great. This is a little bit of a general question. Let me know if it's an easy answer or not. It's from Anne. How can you get full mouth debridement paid?
Okay, so full mouth debridement, first of all, you always, you don't do it the same day that you do a comprehensive. So we talked about that already. The evaluation code, if you're looking for one, is the limited evaluation code because you had to do a limited evaluation in order to diagnose that the 4355 was needed, right? So the offices that have been successful with this, myself included, is that we had great pictures of just how messed up the mouth was. So when the insurance consultant takes a look at just everything that's on those teeth, the inflammation, just I mean, you know what it looks like. I don't have to get graphic with it. This is when intraoral images really, really help. Now, that being said, there are absolutely plans that never cover for 4355. But in my experience, once intraoral images became common, I got a lot more paid than I used to. So that's how I would do it.
Messed up. I would just like to know if that's actually a clinical term.
You know what? There are times I want to make it one. There's other terms that are worse than that.
I bet. So no worries, just teasing a little bit. So this is from Dr. Stephen. He's an orthodontist. Okay. He says, as an orthodontist, he uses a BIOLASE laser, I would assume a diode, to uncover clinical crowns, do frenectomies, and remove hyperplastic tissue from the second molars to aid in eruption. These procedures will allow placement of orthodontic brackets. Mm-hmm. There isn't a specific question about that, but I think the general premise is there coverage for those types of procedures as an orthodontist?
I have seen coverage for that. There is a uncovering pericoronal. I will actually, and I know, David, you always give me the questions afterwards. I would love to send that.
I do.
Answer to you. There is a code for that I've been successful getting. But again, it really does depend on the plan. Plans are so varied nowadays that if I said something was really well covered today, in 3 months, it may not be the case. So it really does depend on the plan. But again, intraoral images are great for that. And always make sure that the patient's aware of that extra charge. And I'll make sure to send that to you.
Oh, please do. Yes, and for everyone's benefit, I do copy all the questions and send them to Teresa afterwards so that she can see them. Teresa's actually agreed to a series of these for us. So there's one basically, without looking at the calendar, every 3 to 4 weeks. I'll talk about that in a moment, but we certainly can follow up. In other words, if Teresa gets a question sort of regularly, we can build that into her presentation ahead of time and maybe pre-answer it a little bit. The follow-up question from that doctor, I think you just touched on. He said that he takes pre and post photos and submits them. You just talked about visual evidence there, so I think we're covered.
Oh, good. Okay.
So yes, absolutely. Let's see. Going back, there was an osseous crown lengthening. It's from an anonymous attendee, so you'll know who you are. It's very mysterious. If performing crown lengthening on a periodontitis site, then do they have to use the osseous code? I'm sorry, it's not written quite clearly. If performing crown lengthening on a site that is periodontally involved, then do they use the osseous code?
The clinical crown lengthening is meant to be done in a healthy environment. So it is. There is another code for that, and I apologize, it's not coming to mind. But again, I will build this into the next one because there is a specific code for that. And if anybody knows it off the top of their head, if there's any insurance brothers and sisters out there and you know it, go ahead and pop it in the box. I can pull up, I don't want to pull up my spreadsheet of codes because that would disturb the presentation, but I can build that into the next one. And anonymous, if you want to contact David or contact me and uncloak yourself, I'll be happy to answer that for you.
Yes, that's great. So, well, I think that takes us right to the top of the hour. We got through most of them. Some of the other questions are not clinically oriented, but there is a question I did want to put in front of you. Let's see. Anonymous attendee. So it could be the same one, who knows? But the question is, what kind of in-office training do you do? And that's probably nice to leave us today.
Oh, sure. I do a lot of virtual training, actually. So because of COVID, that's really been, it's been kind of nuts. So I can do one session, up to 3 sessions to get you guys going, get your insurance systems, evaluate your insurance systems, or just provide general training. So happy to do that. And really even happier to do it virtually, actually.
Yes. Planes are overly full these days, Teresa. Yeah. So you're probably smart to do that. So anyhow, I'm going to switch to some CE before we say thank you and goodbye to you.